I am Dr. Ansuman. I am practicing as a consultant medicine in Batra Hospital, South Delhi. Every day we used to see many diabetic patients who are in some complications in cardiovascular disease, some foot disease, some any other infections. And we are discussing today about the established cardiovascular disease with diabetes, why we should be careful in managing properly so that the cardiovascular disease comorbidities is definitely lowered and patients should have a good, fruitful life till the end of his life. For that, we can discuss one case. The case studies will help us in some amount of our observations, some discussions, and some future any other thing we can do better for the patient. Our patient, Mr. A.B., who is 53 years old, male, a corporate executive, who was diagnosed diabetes 6 months back. He came for a routine checkup with complaints of weakness over the body. He has a family history of positive for hypertension and myocardial infarction also. He used to smoke heavy almost since last 30 years, but has quit 5 years ago, and he is maintaining his lifestyle in a healthy manner. He also gave a previous myocardial infarction 3 years back. So, in history, he has a strong family history, heavy smoker, but quit 5 years ago, and 3 years ago has a myocardial infarction also. He was diagnosed as weakness in the body. Most probably what we can see that we have to maintain his proper lifestyle so that he will lead a proper healthy life later on. On examination, his weight is 92 kilo. Height is 5 foot 8 inches. So BMI is around 30. He is mild obese. Blood pressure is 90 over 40. On lab finding, his HbA1c is 8.4. LDL cholesterol is 137. HDL is 37. Triglyceride is 156. His eGFR is 65 ml per minute per meter square. He gave a history of drug intake of tablet metformin 1 gram twice daily. For hypertension, he was taken telmisartan 40 mg once daily. For dyslipidemia, he was on atorvastatin 10 mg at night. And somebody has added amlodipine 5 mg once daily along with telmisartan. He was taking aspirin and clopidogrel combination also at night. What is the approach to the management of in this complicated patient of previous strong family history, smoking, MI in the past, with obese, with HbA1c of 8.4, dyslipidemia still persists of despite taking anti-lipid measurement, but renal function is mildly normal, it is 65 ml per minute. So we must see about his cardiovascular protection, microvascular protection, weight reduction, glycemic control without any hypoglycemia, and all those should be well scheduled so that he can lead a normal executive in life in a corporate setting. The optimizing glycemic control for cardiovascular risk reduction is by adding some medication in diabetic control. Definitely, one is DPP-4 inhibitor and SGLT2 inhibitors. It may be combined or it can be given separately. By adding this SGLT and DPP-4, the cardiovascular and renal protection is achieved. This is a simple regimen also. Early and durable achievement of glycemic control, more than 1% reduction in HbA1c happens with significant weight loss due to SGLT, and hypoglycemia is less due to our SGLT and DPP-4, both drugs leading to less incidence of hypoglycemia. As you know, that cardiovascular disease is a leading cause for morbidity and mortality in diabetes. It occurs in 12 to 15 years around after the diabetes has diagnosed. The cardiovascular disease is estimated that at least twice that of those of non-diabetic person and associated cardiovascular risk happens in diabetic persons twice around. The Framingham study suggested that 2/3 of the patients of diabetes have subclinical cardiovascular disease. An increase in diabetes also increases the risk of subclinical cardiovascular disease and risks increased in the vascular wall thickness also, leading to atherosclerosis. In SGLT2 different studies in journals, we found that one is EMPA heart studies, that is effect of empagliflozin on cardiovascular structure, circulating biomarkers in patients with diabetes type 2 type. In patients with diabetics, showed that empagliflozin result in early significant reduction in left ventricular mass, regress as detected by cardiac MRI, and suggests that reverse cardiac remodeling may be possible in SGLT2 inhibitor patients aging and leading to cardioprotective effect. Around 2015, the era of evolving dimension of cardiovascular care in type 2 management with EMPA-REG outcome study demonstrate that significant benefit in empagliflozin in cardiovascular mortality reduced by 38%, and major adverse cardiovascular risk is also reduced in diabetes with cardiovascular disease. All types of CV deaths were reduced with empagliflozin. More prominent benefits were observed in heart failure related death and sudden death. It also demonstrated that cardiovascular mortality, irrespective of prior cardiovascular events like any stroke, any myocardial infarctions, heart failure burdens, chronic kidney disease, baseline HbA1c level. Also, it should be add on to the metformin tablet, SGLT and DPP-4 should be added so that our patients can get benefits from cardiovascular death in later part of their life. Several mechanisms were proposed why CV effects of SGLT2 inhibitors. One is osmotic diuresis, natriuresis, leading to decrease in blood pressure, decrease in arterial stiffness, decrease in vascular resistance, weight loss, decrease uric acid and oxidative stress products in the blood also. SGLT2 inhibitors promote reverse cardiac remodeling evident in MRI, cardiac MRI, improve myocardial energetics and filling conditions also by reduced left ventricular wall stress, reduction in mass, and reduce the blood pressure and arterial stiffness also. Another study is EMPA Heart CardioLink 6 study demonstrates that empagliflozin could produce early reverse in cardiac remodeling in diabetic and stable coronary artery disease. We have seen in Carmelina and Carolina trial that linagliptin demonstrate cardiovascular and renal safety secondary endpoint of linagliptin versus placebo or active competitor when added to a standard care of patients who are at higher risk of cardiovascular complications. If empagliflozin and linagliptin is combined, that is available as Azadio, it is seen that after 24 weeks of trial, EMPA-LINA part showed statistically significant HbA1c reduction with a p-value of less than 0.001 when it is added to a patient who is on metformin already. The HbA1c reduction is 1.81% and at 24 weeks. So combination offers a suitable component in strategically to achieve the target HbA1c without any evidence of hypoglycemia, weight reduction with high baseline HbA1c together with cardioprotective benefits in the patient. So what we have learned from our discussion that a patient who is a stressful life, who do not want to be hypoglycemic during his working time, who is a heavy smoker but reformed 5 years ago, with strong family history and obese, with dyslipidemia. So, as per our discussion, we must add a SGLT2 inhibitor and DPP4 inhibitor along with our metformin to control our diabetic, some amount of our hypertension and our heart failure and arterial stiffness. Everything will be less in later part of his aged life. Thank you.